so much for having me with you today and taking the time to consider this really critical topic. My name is Sarah Nagel-Yang. I am an associate professor of psychiatry at the University of Colorado and the medical director of our Women's Behavioral Health and Wellness Service. Okay, I don't have any relevant disclosures for today's talk. This is just a little bit about what to expect during this hour. I'm going to start by giving an overview of perinatal mental health disorders, including the prevalence of specific conditions, the etiology, sort of why is the perinatal period a time of vulnerability in terms of mental health. We'll talk a little about the impact and then go into some specific conditions or diagnoses. We're going to spend the majority of our time talking about screening, starting with sort of the guidelines and considerations for implementation, but then moving to sort of what happens next or how to plan for a response to screening. My goal is to end with about 15 minutes left so that we'll have room for questions. I hope that I'm able to do that. There is a lot to cover. And also, just an FYI, we do have some poll questions built into the presentation just to get some feedback along the way. And at least one time I'm going to ask for some comments in chat. So I'll definitely be looking for all of your input as we move forward. Okay, so starting with this first poll question. There it is. Awesome. Okay, so the poll question is, which of the following conditions is most common among perinatal people? And maybe Callie, I don't know how to tell when everybody's answered or what the results are, so maybe you could help with that part.
Yeah, so we have 14 out of 16, so I'll show our results. I think that's a good amount.
Awesome. Okay, very good. So about half and half divided between perinatal depression and anxiety, which makes a lot of sense. Okay, so when we talk about perinatal mental health conditions, what is it that we mean? Well, just like in other times of life, mental health disorders exist across a spectrum of acuity, complexity, and chronicity in the perinatal period. And, I often reflect that when I meet people and I tell them what I do, that I'm a reproductive psychiatrist or a perinatal psychiatrist, oftentimes I'm asked like, oh, does that mean that you treat postpartum depression? And well, definitely I do treat postpartum depression as one of the most common complications of childbirth. I also treat perinatal anxiety, postpartum PTSD, OCD. I also treat women with pre-existing illness such as schizophrenia or bipolar disorder, which persists into the perinatal period. And as each of those scenarios sort of involve a situation with associated risk and a need for identification and treatment, I think it's important that we discuss how to sort of adequately address maternal mental health conditions. And when we do so, we have a broad focus on what that includes, which is inclusive of, but not limited to, perinatal depression. So this slide sort of highlights a lot of the psychiatric conditions that we think about in the perinatal period and their estimated prevalence. We're going to go through some of these individually in the coming slides, but you can look here and see sort of the portion of the pie chart that's colored pink to see how common these conditions are relative to each other, with the baby blues representing really a normative experience of childbirth, depression and anxiety as very common complications of childbirth. Anxiety is slightly more common than depression. And all the way to the bottom right, which represents postpartum psychosis, which is very rare, but a serious mental health condition related to childbirth. And so why is the perinatal period such a vulnerable time for individuals, both for the onset and the recurrence of psychiatric illness? Well, the graph on the left shows sort of the trend of estrogen, progesterone, and cortisol levels during pregnancy. And you can see that starting around 12 weeks gestation, each of these hormones increase steeply, but sort of smoothly until childbirth, when you see this kind of precipitous drop. And while we might all sort of associate cortisol as having effects on the brain, it's not always appreciated that estrogen and progesterone have strong neuromodulating effects as well. So the graph on the right outlines sort of the complexity of the way that estrogen and progesterone interact with basically all of the most fundamental neurotransmitter pathways, which regulate mood and cognition. And while many women experience pregnancy with only mild mood swings, or just sort of feeling frustrated related to the discomforts that come along with being pregnant or postpartum, a subgroup of women we know are particularly vulnerable to these rapid changes in hormone levels that occur across pregnancy and really impact the body and the mind in complicated ways. And so, it makes sense that women who experience perinatal onset mood disorders also are at risk for exacerbation of mood disorders during perimenopause or in the premenstrual period. And I'd also, it's not really on the slide, but I characterize chronic sleep deprivation as belonging to the category of biological changes that create vulnerability. Because while, again, sleep deprivation can be a normative experience during the postpartum period, it creates a cascade of sort of downstream effects, which negatively affect health and mental health in sort of many, many ways. And, those are just the biological changes. So many of us are parents ourselves, in addition to working with perinatal patients. And so we are likely to have our own reflections on how becoming a parent might really change our life. So this is sort of the beginning of the list, but certainly not an exhaustive way to describe the experience. But we know, for many people, the perinatal period is a time of role transition within a partnership, a family of origin, an extended family. This oftentimes results in relationship stress, kind of a resurfacing of kind of old wounds or grief related to loss, and resetting of boundaries, all of which can be incredibly stressful. We know that for many perinatal persons, they feel an increased sense of dependency. They realize that they need other people in a different way. And, for people who have experienced dependency in the context of trauma, such as having a history of abuse during childhood, this could be particularly dysregulating. We know that babies are a lot of work, right? That's stressful in itself. Babies are expensive. There's a lot of financial stress. There's a reconfiguration of work-life balance. For many, that includes going back to work way more quickly than is reasonable, just due to inadequate parental leave, and changes in relationships to one's body. I hear a lot of people talk about feeling like their body is sort of outside of their control, maybe for the first time in their lives. A lot of changes are happening. There's a lot of exams that are happening, and feeling like that changes sort of the way that you relate to your physical being. And for, I know Dr. Coons talked about this during the last call, but, for people who have experienced trauma, especially sexual trauma, the physical kind of exam or medical treatment aspect of things can be particularly triggering. So all of those things considered, I guess it can be surprising that there's anyone who experiences emotional wellness in the perinatal period. So hopefully, in addition to kind of understanding the etiology of perinatal mental health conditions, there are several specific known risk factors. And so we're going to be talking a lot about screening for mental health symptoms during this session, but I don't want to lose sight of the importance of identifying risk. And actually, the US PSTF, the United States Preventative Services Task Force, have guidelines that really formally call for clinicians to not only identify people with perinatal depression, but also to identify people at risk for perinatal depression. And as I think all or many of you on this call are in the position of caring for patients at the time of delivery, these risk factors may be really critical in guiding sort of additional monitoring or intervention that might be indicated for prevention purposes. So this slide outlines sort of the strongest risk factors for perinatal depression and anxiety specifically. And these include biological considerations like sleep disorders, mental health considerations, the strongest one being a personal history of a psychiatric diagnosis. 50% of people with postpartum depression have had a history of depression before or during pregnancy. And depending on the study, somewhere between 20 and 45% of women with a substance use disorder will experience postpartum depression. And that sort of association is actually bidirectional, so that individuals with postpartum depression are also at elevated risk for substance abuse or misuse as well. And then we also see things like pregnancy complications or pregnancy loss, low social support, increased financial stress, and the experience of intimate partner violence. Okay, so why is this so important? What's sort of like the impact of these conditions on individuals or family systems? Well, this slide kind of gives a really broad overview of that topic, but I'll say in short that untreated or undertreated mental illness during the perinatal period potentially has far-reaching effects on a perinatal person's physiology. You see things on here like increased risk for premature birth or low birth weight. They impact a person's engagement in care, impact relationships and parenting. And all of these factors really interact in complex ways to create risk for both the individual and the family as a whole. So this is a study that's kind of specifically depression, but I like to include it in all kinds of talks because I just think it does a great job of taking this complex issue and distilling it into sort of the impact on everyday family life. And so this was a couple of studies actually, but they included the same cohort of patients, which were women who were suffering from postpartum depression. And they looked at sort of parenting practices of women who were depressed versus not depressed at 2 to 4 months postpartum. And then the same group of women, those who were again or still depressed at 30 to 33 months postpartum, so coinciding with being a parent of a toddler essentially, versus women who were not depressed at that period. And what they found was that in the postpartum period, women who were depressed were less likely to be breastfeeding. They're less likely to be doing things like showing books to their baby, talking to their baby, and they were less likely to have established routines. And then when they looked at the women who were depressed at this toddler period, they found that they were more likely to be using things like spanking or hitting as a form of punishment. They were less likely to be doing things like, putting limits on TV time, using outlet covers, safety latches, and again, less likely to have that daily routine established. And I think for those of us who work with or know depressed people or have experienced depression ourselves, this really isn't a surprise, because even in cases of sort of mild to moderate depression, what we see is that while the person may still be functioning in a lot of areas, going to work, doing school drop-offs, et cetera, doing those things can be so exhausting and overwhelming that doing more than that feels really impossible. And I think this is kind of the, what this study illustrates to me. And, in addition to these more common everyday impacts of perinatal mental health conditions, it's important and, I would say critical to recognize and keep in mind the risk for suicide. We know that rates of attempted and completed suicide are lower in the peripartum period than in other times of life. However, maternal suicide is a leading contributor to maternal mortality. So this graph here is from the Colorado Maternal Mortality Prevention Program legislative report, which includes data from 2014 to 16. And you can see that the number 1 and 2 causes of death among perinatal Coloradans during this time period were suicide and drug overdose. And I think, when I look at this table, one of the things that always gives me pause, and, especially for those of you who are obstetrical clinicians, thinking about sort of, these things further down the list, things like cardiac conditions, hypertensive disorders of pregnancy, ectopic pregnancy, uterine rupture, sepsis, infection. When we think about how much time in medical or obstetrical training is spent focused on recognizing, responding to, and managing many of the conditions on this list, and we think about those in contrast to the time that's dedicated to the topic of mental health more broadly, or suicide assessment and management more specifically. And I think there's there can be a real disconnect there. And we also have data to inform some ways that suicidality presents distinctly in the perinatal period. So again, thinking about your role caring for people at the time of delivery, it's important to note that you might be the last point of contact with a woman prior to her 6-week postpartum check. And so, when we look at this graph here, we see that, the most common time for maternal suicide to occur and be completed is actually in the later postpartum period, those 9 to 12 months postpartum. But when we look at the sort of the concentration of when suicide can occur, the deaths per day ratio, this study and other studies have shown that the first 6 weeks postpartum is a particularly high risk period as well. And so sort of, seeing perinatal patients right at the time that they're going into that period is a really critical time. And I'll also say that when perinatal women attempt suicide relative to women outside the perinatal period, those in the perinatal period are more likely to use a highly lethal means. And so, certainly, which really illustrates sort of an increased kind of intention behind the attempt. Okay, so we have another poll question. Do we know what, are we able to see the results, or are people still thinking?
Yep, 16 out of 23 have
Okay.
participated. So I was going to give it just another second to see if anyone else wants to participate.
I never know how long to wait for.
Right.
I don't want to rush people either. Awesome. Okay, great. Yeah, so we see the most kind of number of votes for either 2 weeks or 6 weeks postpartum. Okay, so now we're going to kind of go into just a few sort of more specific conditions related to perinatal mental health. So baby blues, this is really considered to be a normative experience of childbirth. It affects 50 to 85% of postpartum persons. It is important to know that baby blues is really a transient phenomenon. So I hear from people, that they feel this kind of mild, irritability, or sort of feeling like one common thing that I hear is like, I'm crying and I just don't know why I'm crying. I don't even feel sad, like feeling this more emotionality than one might be used to. Feeling tired, which, makes a lot of sense in this context. But, I think it's important to know that these are usually pretty mild symptoms. They're not pervasive. So I don't hear people that I categorize as having the baby blues saying things like, I'm feeling really low, worthless most of every day. That, would be much more concerning for depression. And then knowing that baby blues resolves in the first 2 weeks. I mean, I think on average, it's more like less than a week, but up to 2 weeks can still be considered baby blues. So if you're seeing somebody at that 6 weeks postpartum check, it's no longer going to be categorized that way. The other thing to know about this is that, the response, can be reassurance, right? This happens to most women. This is a normal kind of probably hormonally driven experience. Education, but also monitoring, because even though this is a normal experience, women who experience baby blues are more likely than women who do not to have postpartum depression at a later point. And so it's definitely a reason to keep an eye on someone. Okay, so perinatal depression, anxiety. These are the most common complications of childbirth, and certainly the most common perinatal mental health conditions. 1 in 7 perinatal persons will experience depression. 1 in 5 will experience anxiety of some type. Obviously, there are many types of anxiety disorders. As well, anxiety and depression are really highly comorbid outside the perinatal period, but even more so inside the perinatal period. So I'll show you a slide later when we're talking about screening that showed that women who screen positive on the EPDS that are found to have perinatal depression, 80%, more than 80% of those women will also have a clinically elevated anxiety symptoms. And so these two kind of conditions really most of the time occur together. Okay. And while sort of by comparison, bipolar disorder is much less common and it affects only 1% to 2% of the population, it does have particular importance in the perinatal period, both because of the complexity of risk associated with treatments for bipolar disorder, anticonvulsants or lithium, but also the risk of the underlying illness. So what do we know about bipolar disorder in pregnancy? Well, first, we know that pregnancy is not protective against mood episodes in those who have bipolar disorder. Patients with bipolar disorder who go off of their medications are just as likely to experience a relapse of illness during pregnancy as any other time of their life, right? So, which is very high. If you have bipolar disorder type 1 and you go off your medication, there's a very high chance of recurrence. But I think, even perhaps more importantly, we know that the postpartum period is a particularly high risk time. So for women, the postpartum period is actually the time point where they have the highest lifetime risk for new onset bipolar illness. So among women, you're more likely to kind of first present with bipolar disorder during the perinatal period than any other time point in life. We also know that for those people who have known bipolar disorder, it's a very high risk time. So one study showed that among people with bipolar disorder, they were 23 times as likely to require psychiatric admission during the first 4 postpartum weeks relative to any other time in their life. And these are people that have a diagnosed illness. So we're going to return to this topic when we talk about screening, because not only are mood episodes really common among postpartum patients with bipolar disorder, it's important to know that the most common type of mood episode in that context is an episode of depression. And so much so that actually women with bipolar disorder are more likely than women with recurrent depressive disorder to present with postpartum depression. And so it's just really something to kind of keep in mind when we think about screening for postpartum depression. And then finally, while we know that most people with bipolar disorder who experience pregnancy will not experience postpartum psychosis, again, it's a very rare condition, having a history of bipolar disorder is one of the strongest known risk factors for postpartum psychosis. Okay, and then finally, postpartum PTSD. So this really refers to PTSD that results from childbirth. It's important to recognize that childbirth may be experienced as traumatic to the patient, even outside of how sort of healthcare providers might define a traumatic birth or a severe maternal event. So the risk is really more about the patient's experience of the event rather than the specific events that have occurred. And what you'll see in this condition are things like nightmares and flashbacks. Again, that's very typical or diagnostic for PTSD. In this context, they often have to do with the childbirth experience. You'll see dissociation, even during medical exams, emotional numbing, feeling more detached from their partner, from their infant, and sometimes even avoiding places like the hospital that bring back memories or care of their infant, again, because care of their infant may be triggering in this context. Okay. So that was a lot of information about sort of, perinatal mental health more broadly. Now I'm going to shift to talking about screening, specifically focusing on what to screen for and how to screen. So when we think about conditions like perinatal depression and anxiety, perinatal substance use disorders, intimate partner violence, I think many of us would agree that they sort of align with these components of conditions for which universal screening is indicated. So they're common. We know that they're associated with adverse effects. They have complicated risk factors that we might not always appreciate in a typical healthcare encounter. They're treatable or actionable. They're things that we can do to help. And screening for these things, does have only a minimal time investment. Okay, So question for the chat, if you wouldn't mind to share. What are the challenges that you've seen in your setting with implementing screening? I just sort of outlined, how straightforward it is that we should be doing this, but I also know that it's not always easy. So I'd love to hear if you can type in just a couple of words about challenges that you've encountered. Staff capacity, yes. Yeah, having a standard tool that works across settings. Resources, yes. Okay, well, this is really helpful. Yeah, so these are some commonly reported challenges, and I think it's really important as we talk about screening not to lose sight that this is not so easy to implement, particularly depending on resources in a given setting. So providers are busy. There's a lot to do in the healthcare encounter, and so certainly a lack of time is a big one. A lot of us, worry about not having the right response or not knowing what to say if somebody screens positive. For sure, there's a real concern about psychiatric services being available, and particularly if the patient has more of an interest or need for therapy, and depending on the patient's insurance and access issues, this could be a real barrier. Some of us worry that the patient isn't going to like being asked these questions. I think that that's something that again and again we've learned, isn't usually true. Patients really do appreciate when we ask them these questions. There's a fear of liability, and hopefully this is an outdated one, but historically there's been a concern that asking about depression seems outside the scope of OB/GYN care. I would imagine that most people on this call wouldn't agree with that, so I probably won't need to spend much time on that. Okay, so one of the most important components to addressing these challenges, like time, comfort, referral options, are really to develop from the very beginning a thorough plan for what screening should look like in your setting. And I'd say in this case, the more detailed, the better. And that kind of time invested up front will pay dividends by saving time at later points, trying to figure out what to do in different situations, and also helping to support a smooth process for patients and for the providers as well. And so while each of these things could really be a talk in itself, I'm going to briefly kind of touch on these components of sort of workflow, identification of tools, frequency of screening, and then components of an evaluation, a screen positive response, which should include an evaluation, a suicide assessment sometimes, and also perhaps an intervention or a referral. Okay, so starting with perinatal depression, this slide kind of provides an overview on guidelines around perinatal depression screening from several organizations, including ACOG, APA, which is the American Psychiatric Association, the USPSTF, American Academy of Pediatrics, American Academy of Family Physicians. And so you can see all the details written out here, and I think hopefully I'll be able to send out a copy of this slide deck. But I'll say the summary is, one, essentially any organization that's concerned about the health of perinatal persons and families recommends screening universally for perinatal depression. And two, the most common recommendation is to screen at least once in pregnancy and at least once in the postpartum period. And I know that you all are working in inpatient settings, so I'll add that while there are not sort of formal screening guidelines that are specific to inpatient settings, there are a couple of reasons why I think it makes a lot of sense. So first, for the antepartum patients, as we've discussed, there's sort of this very high correlation between perinatal depression and obstetrical complications. So, people that are hospitalized for obstetrical risk during pregnancy are a particularly high-risk group. Two, at the time of delivery, patients are kind of entering into this high-risk period, the first 6 postpartum weeks, which is an elevated period of risk for suicidality. And lastly, most will not have another point of contact until their postpartum check, and some, won't attend that postpartum check at all. And so while I do think that in some cases, it's sort of difficult to confidently diagnose postpartum depression in the immediate postpartum period, a positive depression screen at that period could really be a critical part of identifying someone who needs a higher level of care, or in other words, closer monitoring than what is typically provided in the postpartum period, as well as, potentially identifying someone who's already having suicidal thoughts. Okay. And on a related note, I think while the USPSTF is the only organization that's formally put forward a recommendation that obstetrical providers identify patients at risk for postpartum depression, this is a topic that's really of active interest and, maybe particularly pertinent to inpatient obstetrics care. So this table, I'll say, is from a group at University of Pittsburgh Medical Center, who is using this set of risk factors to identify patients who are inpatient on either antepartum or postpartum floors, who may need closer follow-up or even a proactive referral to mental health services, regardless of their actual depression screening scale score. And in fact, we have a similar service at University of Colorado Hospital, which is called the Perineal Pathways Program, that works in a very similar way and utilizes very similar criteria. And we know that it's important to think more broadly than only perinatal depression. So ACOG guidelines also support universal screening for anxiety, at least once in pregnancy and once in the postpartum period, universal screening for intimate partner violence at the first prenatal visit, at least once per trimester and at the postpartum check, and also targeted screening for bipolar disorder and those who screen positive for postpartum depression. So a positive EPDS scale warrants a screen for bipolar disorder, especially if you're considering starting medication, as well as screening for postpartum PTSD for those who have identified a traumatic birth experience at that postpartum check. Okay, so moving a little bit into the how, a common question is, what are the tools I should use? And I think for depression, most of us are familiar with the EPDS, which is the most commonly used screening tool for depression in the perinatal period. It's people like it. Number one, it has very good psychometric properties. It's short, it's only 10 questions. It's available in lots of languages. And, while the PHQ-9 is also, a useful scale and certainly would be a reasonable option as well, many prefer the EPDS because it controls for somatic symptoms. So questions about fatigue or changes in appetite, which can be normative experiences when you're a perinatal person, aren't sort of pathologized in the sense of a depression symptom with the EPDS. I listed a couple other nice kind of options, although these are much longer, as you can see. And so, I think they're really useful if you have somebody with depression and you're wanting to track symptoms over time. They're a little bit more nuanced in that way. Okay, and then how about other kind of conditions? Well, there are lots of validated self-report scales for anxiety-related conditions as well. For those of you who are already using the EPDS, I think it's really straightforward, perhaps, to add in an analysis of the anxiety subscale. So you can see the 3 questions that make up the EPDS 3A on the right-hand side. So you don't have to give another questionnaire, but you can use the same information and look for anxiety distinctly as well. The GAD-7 is another short questionnaire commonly used in primary care settings. And the other scales mentioned on the slide are kind of longer, but again, more effective at monitoring change over time. And for reference, I've also kind of added some validated scores scales for bipolar disorder, intimate partner violence, and postpartum PTSD. Okay, so moving, I guess, a little bit further into the how of screening, I'm going to outline just a few key points here and then follow up on each of them. First, I think it's really important to know that when you are implementing screening, that is happening in the context of your relationship with the patient, right? And how you engage with the screening or introduce the screening will really set the tone for the patient's experience of being screened, and could actually influence the degree to which the patient is willing to share an view of their symptoms. As we're looking at screeners, some of them, including the EPDS, have questions about suicidality. If that's the case with the screener you're using, it's really important to not only look at the overall score, but also look at that particular question, because even if the overall score is sub-threshold, you would want to follow up on suicidality, of course. We know that positive screening, it doesn't mean that there's a diagnosis. It just means that it's a reason to have an evaluation. And we also know that screening, while important, isn't actually the goal, right? The goal isn't just that we do screening. It's that by doing screening, we identify people who are suffering with perinatal depression or anxiety, and that we are able to have an intervention or a referral that reduces suffering and improves health. So thinking about sort of how to utilize your relationship with the patient in the screening process, I think it's important how we introduce the screening. And particularly, the aim would be to establish a sense of trust and kind of really allow the patient to know, this is why we're asking, we care about you, and, this is a safe place to tell us what's going on. This is an example from a place, where I have my previous place of employment, just one of the practices I was a part of. And this is what we gave to patients. So back then it was a paper packet. This was like the introduction letter at the on top, and it said, "Dear patient, at the Rainbow Center for Women and Children, we care about the total health and wellness of every patient we serve. As part of our wellness program, we ask that a variety of screenings be completed so that our providers have a better understanding of our patients. We've added screenings about mood, worry, life stress, as well as about strength and supports. These forms ask some personal questions. We'll keep this confidential among our team. Thank you for partnering with us during your maternity and postpartum care." So in this very brief paragraph, I think that we attempted to really say we're asking because we want to know, and we ask everybody, not just you for any particular reason. Okay, and how about after screening is completed? These are just some kind of considerations in terms of, again, continuing that relationship as part of the screening process.
We had one question in the chat that might be helpful to answer before you go into the follow-up. The question is, what score would you seek additional resources on the Edinburgh screening tool? So what score counts as elevated?
Yeah, so there are definitely different cutoffs. The cutoffs that I've used in my practice have been anywhere over 9. So 10 and up is a positive screen. But I would say that if I had somebody who had a score of 6 to 9, that, thinking about screening, if I were screening in an inpatient setting right after the patient had delivered, and thinking about, what kind of supports need to be in place. If I saw a sub-threshold scale, but an elevated one, so maybe in that 6 to 9 range, that might be somebody that I would think about for a 2-week postpartum check versus 6-week, or other resources depending on what's available to you. Okay. So in terms of follow-up, I think in an inpatient setting, I think it's always important to reinforce the need for privacy, right? That they're busy places, they're visitors. We never quite know sort of the relationship, or, to what degree there's trust in a relationship. And so coming into the room to talk about a screening result, I think is a really good time to ask visitors to give privacy. I think it's important to thank somebody. They went through the process of filling out a questionnaire or multiple questionnaires, and so thank you. I think is very relevant. And then it's always important to, if I fill out any kind of questionnaire in any doctor's office, I kind of want to know, okay, what's my score? What does it mean? Regardless if it's positive or negative. And so I think it's really important in terms of the relationship to give feedback. And then if it is positive, being very straightforward, I guess, concerned, but sort of, just like you would follow up on other things and other conversations, allowing the patient to feel comfortable, that you feel confident having that conversation as well. Giving information about, again, why you screened, and then asking their permission to say more. So I think it's always, helpful to think about how you might say this in a way that feels natural for you. But, I always like to give some kind of examples of what I say. So those are things that feel natural to me, just to kind of give some language. So, I might say to a patient, thank you so much for completing these questionnaires. I noticed that your score on the depression screener was a little bit high. It was 15, and we really consider anything over a 10 to be a positive. Would it be okay if I asked you more questions about that? Or I noticed in your packet, you reported having a lot of worry or anxiety. Perinatal anxiety disorders are really common and they're treatable. So we always ask about them. Can you tell me more about what this has been like for you? Or, I was thinking about, some of the intimate partner violence screenings. And that can be a particularly challenging conversation to have. And so starting with something like, thank you for trusting me with this information. I want you to know, like, this isn't your fault and you don't have to figure it out alone, right? So letting people know that there is some hopefulness in the conversation, but also that you appreciate the trust and the bravery it took for them to tell you about it. Okay, so what about suicidality? So anytime the patient answers a positive answer to a suicide question, so this would be the Edinburgh question 10, any response other than never, we'd want to ask more about it. And these are kind of the components of a suicide inquiry. And when we think about an inquiry, there are really four main components. So first is just asking about their thoughts, the same way that you might ask about if they said they had chest pain or abdominal pain. Asking about, like, what are those thoughts like? How often do they come? How bad are they? Is there anything that triggers them? Just really getting a characterization of the thoughts. Second, asking if they have any plan, if they have any ideas about how they would follow through. Intent, if they're planning to do this, have they taken steps towards their plan? And then access. So if they are saying that they are having thoughts about wanting to overdose on pills, asking, like, what kind of pills do you have in your house? Are there people in your family that have pills that you know about, that kind of thing? So again, some language that I use, it may or may not feel right to you, but I noticed on your depression screen that sometimes you have thoughts about hurting yourself. Can you tell me about these? What thoughts are you having? When you have these thoughts, how long do they last? How often do they come? How strong are they? What stops you from acting on them? And how easy would it be to shoot yourself? Do you have a gun in the house? And then one of the questions that I always find really meaningful is, if you weren't alive, what would happen to your children? And I hope that I say it in a way that doesn't sound provocative or challenging. It's really a question. And I get very different responses. Sometimes I get, well, of course, that's why I would never do that. I don't have anyone who would take care of my children like I do, or I would never do that to my child. And sometimes I get a response like, well, actually, I'm such a bad parent. My child would be better off if I weren't here anyway. And that's particularly concerning. Okay, so this is, I think after you ask those questions, similar to other things, you would want to come away from that conversation with an idea about level of risk. This is actually a resource from the Australian government. I just really like it because I think it does a good job of sort of saying, like, here are some different responses and here are different examples of suicidality that can fall in these different risk categories. And as you can see, the response could be anything from sort of making sure the patient has follow-up if they're just having sort of fleeting thoughts that don't happen very often and they have no intention or plan, all the way, of course, to hospitalization. And, I think it's important to know about safety planning. I think, in psychiatry, this might be a little bit more within the scope of what we do. But I think it's useful just to look at what a safety plan looks like for somebody that's more in that moderate risk category. So this is a safety planner that I use. And it starts with warning signs like, hey, what is it that I notice about myself when I first start to not feel well? An inventory of coping strategies, right? What do I do? What do I have within my own kind of control that I can do when I'm starting to feel, when things are starting to escalate? Step 3, who do I reach out for if I just want to, like, have some distraction? I want to go have a cup of coffee and not talk about any of these things that are on my mind, but I just want to get out of the house, right? And then who are the people who I can actually talk to for help? Who can I actually talk to about what's going on? And those could be very different people. Professional, so of course, the Colorado Crisis Line, the National Suicide Prevention Line, that would be the next level. And then, after I've reached out to those professionals and I'm really feeling unsafe and we put together a plan, in the meantime, what can I do to keep my environment safe? Can I give my gun to somebody in my family outside of my home so it's not here? Can I get the medications out of my house that I'm not taking anymore? And then I really like the last one, which is, what's one thing that keeps me going? Because while, I might be sitting with a patient who has some level of suicidal thoughts, if they're not actively suicidal at that minute, they can list a lot of things that keep them going. But in the midst of kind of a higher level or exacerbation outside of my office, those might not come as naturally. So having them identify those things for themselves can be really helpful. Okay, I'm going to skip the last poll question if that's okay, just because I want to make sure we have time for questions. Infant harm. So if we're asking about suicidality, it's really important to ask this question as well. It's common for moms to experience thoughts about harming their children. Does that ever happen to you? And when I say it's common, it's because it is really common. So almost every woman has a thought about something happening to their baby, right? Like that's a very common just thought to have when you are a postpartum person. And about half of postpartum individuals have thoughts about intentionally harming their babies. Fleeting thoughts, things they would never do, but just, thoughts that come and go. And so, it is a really common thing. If somebody says, yes, actually, I have those kind of thoughts, I wouldn't be surprised because I would expect that, half of people that you ask, if they're feeling safe to tell you about it, they half of the time they'll say yes. So it's really important just to follow up with the same kind of questions, like tell me about the thoughts. How often do they come? What are they? How strong are they? How likely do you think you are to follow through on this? Do you want to follow through on this? And getting kind of a characterization so that you can better determine the risk. Okay, so as we're talking about screening, I just also want to recognize that while screening is important, there are definite limitations. So these are some limitations, it's not all of the limitations. So certainly people with a lot of life stress going on. So people that are hospitalized and worrying about who's caring for their toddler at home. People who have just been given feedback about their health that's distressing. Somebody who's experiencing a pregnancy loss, right? If you give somebody who has a lot of stress or distress at that moment a screening, they might report symptoms and have an elevated score, but not have depression, right? And so certainly screening does not equal diagnosis, but also a negative screen does not definitively rule out depression or anxiety, right? So standard depression screeners don't do a good job of detecting depression in people that are from cultures that are more likely to exhibit somatic or physical symptoms of depression rather than endorsing depressed mood, for example. And standard depression screeners may not detect depression in the context of stigma or distrust. We know that patients who are part of historically marginalized communities often face additional barriers, right, to disclosing depressive symptoms, including fear of referral to child protective services, or fear that sort of telling somebody, a healthcare provider, about their depression or anxiety would result in their sort of their other concerns about their health being discounted, right? And so it definitely is happening in the context of a lot of other life and culture and, in expectations. And so there are a lot of limitations, related to that. We also know that, screening does not equal a specific diagnosis. So this is a table from a 2013 study. And this study basically took women who screened positive with the EPDS, and they followed each of those positive screens with a structured psychiatric diagnostic interview to get a kind of definitive diagnosis at that time for each individual patient. And what they found was that of women who screened positive with the EPS, about, I think it says 68% had depression, right? So that's pretty good, but there's a lot of women that were diagnosed with something else. The most common something else was bipolar disorder. So again, going back to the conversation about bipolar disorder, 22% of patients in this study, and this has been consistent in other studies as well, it's about a quarter of patients, if you're looking at screening in the postpartum period, when they screen positive, about a quarter of patients will have bipolar disorder. And then when you look at sort of women who screen positive and did have depression, you see these secondary diagnoses again. So anxiety, very highly comorbid. And for substance use disorders in this study, it was about 10% of people who screen positive with the EPDS also had a substance use disorder. Okay, so I think I'm gonna kind of skip through these last ones just to make sure that we have time for questions. But essentially, you know, you can reference this table. This is a good way to kind of categorize, you know, sort of mild, moderate, and severe with some kind of corresponding recommendations for treatment. I think a thing that I would highlight about this is that it's really important to ask each patient, like, hey, you know, your depression scale score is this. This is, you know, I'm worried about it. You know, here are some different treatment options. What sounds good to you? And I think even in the setting where it's like somebody with a more severe depression, even though we might know that medication would be indicated, certainly many women will prefer to start with psychotherapy. And I think, you know, starting kind of where they are, not being inflexible about our recommendations is really important because those can become barriers. Okay, and then this study is really just about, you know, the fact that our traditional screen in an OB setting or primary care setting, identify depression, and then give them a phone number and ask them to follow up with a mental health provider has some major limitations, and actually the vast majority of the time does not result in treatment. And you know, I think that has a lot to do with the fact that we're asking a patient who may be under a lot of distress or depression or anxiety, have a lot of barriers to navigate these systems that are all kind of siloed from each other. And this is a slide that I often show obstetrical residents, just when it's like a frustration about like, why do I refer and my patient doesn't come? There are many, many reasons why the patient might not come. And, you know, I get really excited about models where we come to the patient, right? Where we as healthcare providers can be a team around the patient versus asking her to come to each of our individual settings. And I think there's been a lot of advancement in that way. I've been very fortunate to work in a lot of those kind of settings myself. And I think they work really well for all parties considered. Okay, so in conclusion, you know, I think recognizing that perinatal mental health considerations occur across a wide spectrum, acuity, duration, diagnoses. We know that screening is feasible and acceptable, but it really needs to be followed by evaluation and a personalized response. And we really need to be thinking about barriers to care. These are some resources that I use almost every day, including, and then also this is the Colorado Center for Women's Behavioral Health, where I practice. And, you know, we do a lot of telehealth across the state. We have psychiatry, psychologists. So if we can be a resource for your patients, you know, we'd be happy to be. So I will pause there for questions.
I have a quick question. This is Leisha Anderson. Do you think that there's availability of appointments for those that want them? Do you think there's any limitations on that end?
So I definitely think there's an access issue. Yes. I think that, you know, one of the things that I think a lot about as a medical director, I guess, is how to be more flexible in how we manage referrals such that we have urgent patients, you know, we have urgent slots for people who come in or needing, you know, care that minute. And then we have a slightly different or more personalized approach. You know, sometimes I get a lot of referrals of people who want to have a baby in a year and wanting to talk about their medicines, you know, so that person might not need the same slot that an urgent patient. So I think there's a lot that we can do to try to triage how we manage things, more effectively. I think our service, right now we have pretty good capacity. It ebbs and flows though, depending. And I think that's the case for a lot of people. So I think there are barriers. I definitely think that having relationships between providers helps, because if I hear from another provider like, hey, I'm really worried about this patient, there are definitely ways to be more flexible when I know there's a need.
And with you all having capacity, is this something that some people do through, telehealth? Like, what about people that are in different parts of Colorado?
Yeah. So I think telehealth, and before COVID, I had never done one telehealth visit. And I wasn't here, so I don't know if it's representative of our department, but it just wasn't a thing that was feasible for a lot of insurance related reasons. Those have all been, everything has changed. And so I think telehealth has been an amazing kind of way to, even when I have patients who live 5 miles away, if it's a snowy day and they have an infant and they don't have a car, right? Like that's a really hard thing to ask someone to do, but they may be able to join the telehealth visit and often are. So yes, I think, as basically the only barriers that we come in terms of, being able to see someone from telehealth is, number one, if they don't have, the Wi-Fi bandwidth for the visit. And number two, if they live in another state. But all of Colorado, we're licensed in Colorado, so we can see anyone anywhere. And that's the same. I would say all mental health providers that I know of right now are primarily doing telehealth visits.
I have a question about sort of like familial support surrounding recognizing when a mom is experiencing peri or postnatal anxiety, depression, how a spouse or partner or family member could help identify that, have conversations. Have you heard of any sort of training surrounding that? And have you, or are there conversations that are happening within those appointments with the family members? It's a little bit harder, obviously, with COVID, and sometimes there's only so many people that can come into the room, but I just thought I would ask that.
Yeah, that's a great question. And I do think that I couldn't name a specific resource at this moment, but I think I could find one for you that are more like, awareness kind of focused information that are for family members. I think that in my practice, have it like seeing people who typically have already been identified or, are dealing with depression before pregnancy. I often will involve family members, especially as we're getting like later into pregnancy, going into the postpartum period, knowing that like everything's about to get really confusing really fast. And saying like, and making sure that I have release of information in place so that if somebody did have a concern and they reached out to me, we were able to talk freely, knowing that the patient has given their consent. So yeah, but I know that there are some more sort of universally focused efforts, and I can look, I could find something and maybe send it to the group.
Thank you, Sarah, for your presentation. I really like how you highlighted resources that can actually come to the mom rather than the mom having to go to those resources just because of the barriers you've mentioned. My question for you is, do you have or know of any organizations that have like peers that have probably went through similar experiences with pregnancies that can come to the moms and provide a sense of support? Again, bridging that medical and behavioral health aspect. These peers don't have to have credentials, but they can be a form of support because of their lived experience. So do you know of any resources?
Yeah, thank you. So thank you for asking that question. And I would imagine there might be folks on the call who know other resources that I'm not familiar with, but the ones that come to my mind are through PSI. So it's this wouldn't, to my knowledge, I don't know that there's a part of PSI that does home visiting per se, but PSI is Postpartum Support International. We have a very active and well-established Colorado branch that's been, in kind of, had a lot of kind of energy and resources for a long time. And they do a lot of peer-to-peer support groups that are all available on telehealth now. And, you know, they have a lot of different, you know, specifically around, you know, like they have LGBTQ plus support groups for individuals who are coming into parenting. In that context, they have, you know, I know support groups that are specific to persons of color and, you know, and lots of other kind of variations. So they have a very well-developed peer support group kind of thing. And they also have, I think, a program where one of their state coordinators or regional coordinators like call people, you know, and kind of talk them through the process and figure out what might be helpful for them. So that's a very established peer-to-peer support effort. The other thing, which is not peer-to-peer, but is a home visiting program, is the Nurse Family Partnership. And I don't know, that might have come up in your other discussions, but I know that that's a very, very evidence-based kind of approach with a lot of wonderful outcomes. And if other people have peer support groups, like feel free to jump in. I definitely would love to hear about them as well, or peer visiting programs.
At our, we're currently in the middle of improving screenings and resource connections and care transitions and all of these different aspects. And we're considering developing a kind of work group that brings in previous patients that can help us better determine how to help our moms, as well as potentially, I hope, I want to develop kind of meetups or groups that they can come to, support groups that they can have at the hospital that can be like supervised by a licensed therapist that can kind of help with any sort of language or other outside of things that are outside of just a mom necessarily experiencing something. So that's what we're looking into and thinking about.
Yeah.
Sarah, I just put one in the chat. NAMI Colorado, National Alliance on Mental Illness. They have some peer support and family groups. They're not specifically focused on pregnant or postpartum people, but we're having conversations with them too about, you know, potential partnerships and linking up some of that work. But they're a great organization that has groups across the state in different regions. So there are some like local things that folks could tap into for family resources generally.
If no one else has any more questions, Sarah, thank you so much for your presentation. I learned a lot, and from the comments and the chat, it seems like everyone else has learned a lot as well. So thank you very much.
Yeah, thank you so much for having me. It's really, it was an honor to be invited to be a part of this. So thank you, and I will let you guys get to the next part of your meeting.
Okay. Thank you so much, Sarah. So now I am going to move on to presenting about a new program that CPCQC has that I would just like to garner interest in. And I'm just going to share my screen to share this all with you. Can you all see that? Great. So CPCQC has become grant funded for more work on COVID-19 in the state of Colorado. And so I just wanted to share what we're going to be doing in 2022. And if you're interested, you can reach out to us further. So I'm going to talk about what it is, its involvement with substance use disorder, since this is the Substance Use Disorder Learning Collaborative, activities we're doing, what participation will look like, and then how you can get involved. So this is going to be a 7-month project to improve the state of COVID-19 vaccination in Colorado. This is of urgency right now since the state of Colorado having increased COVID cases in the past few months. And the goal of this project, there's a few different goals that we've come up with, but one is to increase the vaccination of people in the perinatal population for COVID-19, improve COVID-19 vaccine access in Colorado, and then improve vaccine confidence for patients on COVID-19 as well as other communicable illnesses, as well as confidence of healthcare providers in providing education on COVID-19 vaccines. So in relation to the Colorado AIM Substance Use Disorder Learning Collaborative, although this is offered to anyone in the state, but specifically this is of importance for this learning collaborative because patients with substance use disorder have an increased risk of being diagnosed with COVID-19, as well as they could experience worse symptoms and have a higher risk of mortality. And this is all new data that I've recently found. Additionally, the CDC reports that 13% of Americans have increased their uses of substances as a method of coping for stress during the pandemic. And then finally, although there is little published research on vaccine hesitancy in the substance use disorder patient population, there is new research showing that substance use disorder patients are more likely to be hesitant against the COVID-19 vaccine. So what we will be offering, which will be starting in 2022, we'll be hosting 4 educational webinars on how COVID-19 might impact the perinatal population. This will be in January, March, May, and July. We will be providing coaching as needed for protocol development for organizations to develop protocols on vaccine dispensing and as well as vaccine education. And then we'll also be providing organizations or participants any resources they might need. So I'm compiling up all these resources on how to develop protocols, on vaccine hesitancy, on vaccinating patients in the perinatal population or postpartum population. So those are just a few things that we will be doing. So involvement would look like completion of a pre and post survey. This is just for us to be able to track changes. Unlike the Learning Collaborative, where we collect monthly data, there will be no monthly data collection. So your involvement doesn't have to be monthly, like the Learning Collaborative. We would like active participation in the webinars. These are going to be 1 hour duration every other month. And some topics that we are having are a topic on vaccine hesitancy in the pregnant and postpartum population, as well as, the impact of COVID-19 on different racial groups in Colorado, and then the impact of the pandemic on maternal mental health. And then finally, we will be supporting you, like I said, on the creation of vaccine protocols in your hospital or organization as needed. We assume that the co-AIM SUD hospitals already have some vaccine protocols in place just from previous discussions, but we are here to support you in your creation of that as well. So finally, how to get involved. We are having anyone in the state who would like to be involved in these webinars to get involved. We want to have as much widespread involvement from the perinatal community. And if you would like to become involved, we have more information on our website, or you can email CPCQC at info@cpcqc.org. So now I'm going to open it up to any questions that you all might have about this project or what offerings we might be having. That's okay if there's no questions as well. Great. I'm going to pass it back over to Katie.
Yeah.
Thank you
I
all
also
for-
wanted to know, for folks who are on the call who work in hospitals, as we're sort of preparing for this program and figuring out what teams need, just anecdotally, any of you who work in hospitals, we are curious if you already have some sort of protocol in place for pregnant people who present on labor and delivery. Like, are you asking about vaccination status? If they're not vaccinated, what do you do? Are you receiving records of their COVID vaccination status, or is it sort of like self-report thing? Anything you could tell us would help us prepare.
Also, if there's any topics that you'd be interested in on COVID-19 vaccination in the perinatal population, I'm also all ears for that as well. We want this to be catered to you.
Anyone? Anyone?
If you have any suggestions too, you can also email them to us.
Well, if no one is in a talkative mood, we can launch our final evaluation poll. Please do fill that out before you leave. And we can definitely keep talking if people have things to say. Chris Tussey said they request the patient receive a COVID test prior to induction and scheduled C-section. Awesome. Christina, are you asking them about their COVID vaccination status in addition to making sure that they have a test done? Yes. Okay. You should be seeing that evaluation poll up on your screen. Please fill that out if you can. Ooh, question. Yes. Has anyone run into Edinburgh and any biases or inequities that the tool may inadvertently cause, if any other health systems or groups have considered this? Yeah, so I think there's been conversation around the fact that Edinburgh might not be culturally relevant to all cultures, like it was validated on basically white people. And one just anecdotally thing I've heard before is like, if the Edinburgh asks you, like, I can't think of the specific question, but like, do you find yourself being worried? Like, for example, if you are a Black person in America, you might find yourself being worried more than a white person in America. And so that's like a very simplified way to explain it. But that is, there's been feedback that Edinburgh isn't culturally responsive. And so what she's asking is, has anyone else sort of dealt with, I think this is what you're asking. You're welcome to come off mute too, Mariah. But has anyone else dealt with or seen this sort of cultural bias with Edinburgh or other depression screeners? And have you addressed this? Are there other tools that you like better? And Mariah, we can certainly ask Dr. Nagel Yang for more on this as well. I know I've been in conversations where basically there's recognition, you know, like among the broader perinatal health community that EPDS isn't necessarily culturally responsive, but I feel like the sort of conclusion is like, yes, we know it's not super culturally responsive, but I don't think we have anything else that's validated that would be culturally responsive. So it feels like it's an issue that no one has really tackled yet, but that the field recognizes. I don't know, like, if anyone knows if anyone is developing something validated that would be better. I know I've been in conversations about it, but I can't say I'm an expert on it, but Dr. Nagel Yang might be. So definitely something we could follow up with her for more info on later.
Yeah, I think that's another piece, is kind of asking the larger group if they've heard of any research that's being done and developing of a new tool. But yeah, thank you. I appreciate that.
Yeah, of course. Yeah, it's definitely a problem and something we've heard a bunch of times before. I just, to the best of my knowledge, we don't have anything better right now. But to your point, like, someone in this group might know that about research that's going on to make it better. Christina said there is current research ongoing about ACEs and postpartum depression. That's interesting. Yeah. But definitely Dr. Nagel Yang is super like tied into the research and follows sort of all the academic development. So she would definitely be a good resource. Okay. Well, if there are no other questions, we can let you go and you can get 8 minutes of your day back. Please do fill out that evaluation poll before you go if you haven't already. And yeah, really appreciate the conversation today, the questions. Please reach out to me or info@cpcqc.org for any follow-ups. And I hope you all have a happy Thanksgiving and get to eat all of your favorite Thanksgiving foods that you put into the chat. And I really hope I, at some point, stumble upon sweet potato that has pineapple in it.